I've spoken in 3 or 4 different parliaments around Australia. I actually have a very positive feeling because of the number of people that are turning up and the engagement that we're getting on this issue. I think we really are starting to see change in a few different areas, so I have a very positive feeling and I'm very glad to see everybody here. I really want to thank Elizabeth and Isla in particular. I think Women Speak Tasmania is doing a fantastic job. Very important to allow women to speak. I realise the irony of me saying that, but hopefully women sometimes will listen when men say sensible things, and hopefully I can do that today. I also want to say I feel like a bit of a fraud speaking between Diana and Gillian in particular, 2 people who have a lot of skin in this particular game. I myself am an academic psychiatrist, means I sit in an ivory tower and think about things, and both these courageous women have actually been both helping kids but also taking direct hits in order to improve their lives. I think they deserve a round of applause. I think I do have something to offer as an academic psychiatrist. It does allow you to have a more abstract view of not only what has been happening, which Diana has so ably told us, but also some of the why what has happened and then how we might get out of that. And hopefully I can describe that today. So look, while Diana, Gillian and Philip Morris, one of our other presenters, have been focused on clinical, legal and institutional features of gender medicine, I'm going to be describing more systemic vulnerabilities of the health system and other parts of our society that have allowed a political agenda to override the usual safeguards that basically keep patients safe. So what has allowed that to happen? Viewed as a medical process, the rapid rollout of paediatric gender medicine across Australia, to me, is a great mystery. In other areas of medicine, even highly effective treatments, supported with solid evidence, can take many years to be implemented in practice. In this area, of course, it's happened in the blink of an eye. Lots of funding, rapid rollout, and instant implementation of very dodgy protocols. Now, inflicting social, medical and surgical treatments on vulnerable children, despite the known harms and the uncertain benefits, violates all the principles of medical ethics. But it's essentially being justified as a natural extension of the long campaign for gay rights. So ultimately, the puzzle of paediatric gender medicine in Australia, I think, is the result of the abandonment of medicine's focus on patients' health and safety in order to pursue political goals. Now, happily, as more people become aware of its harmful methods, the trans tide, as I said, at least to me, does appear to be reversing somewhat, albeit more slowly in Australia than other places. It's a bit of I feel a bit of shame as an Australian that the UK appears to be moving more quickly than us, but hopefully we can catch up. But look, the continuing existence of paediatric gender clinics proves that the medical profession is and has been incapable of preventing the widespread adoption of social, medical and surgical affirmation of what I believe to be mentally ill children. This highlights a large blind spot in the governance framework of modern healthcare that must be corrected to avoid further damage to patients, and I think there's a risk of damage to the reputation of the medical profession itself. So look, my talk's going to look at what has happened, why it has happened, and what needs to change to reverse the harms being done by paediatric gender medicine in Australia. Okay, so just starting with a very brief summary of what has happened. Diana's given us a lot of very detailed information at a more abstract level. Basically, in the 20th century then, medicine and psychiatry acknowledged that there were a very small group of people who experienced distress caused by dislike of their sex. There were many variations with different diagnoses that evolved over time. The most common diagnosis, or the one we recognise most today, transsexual, described a person, usually male, an adult male, who attempted to live as the sex opposite to their biology, with or without surgery and medication. Now, the variations aren't important to the current argument. I'm happy to answer questions if people have them. But what is important is that it was always acknowledged that the desire to be the opposite sex was a form of mental illness, because it was highly dysfunctional, highly distressing, and associated with high rates of psychiatric morbidity, including depression, anxiety, suicide, and other mental illnesses. Now, in the second half of the 20th century, there was growing social tolerance of transsexuals, and a few famous case studies were published that really made them better known. And it became known that most transsexuals' primary goal was to successfully pass as the opposite sex. And that basically required being perceived and treated as their preferred sex by all or most of the people in society. However, it also became clear that it was largely impossible for most adult male transsexuals to pass if they began their transition as adults. So for many male transsexuals, the failure to pass was experienced as society's rejection of their idealised picture of themselves as women. Now, the technical name for this, which Diana has also already brought up, is so the technical name for this type of emotionally damaging experience is a narcissistic injury, and it can cause almost intolerable emotional pain. There is an echo of this catastrophic level of distress in claims by modern trans people that refusing to affirm their preferred pronouns is effectively the same as wanting to destroy them, to wipe them out of existence. This is an indication that this is a form of narcissistic injury that threatens your very being. In any case, the narcissistic injury caused by society's rejection of those male transsexuals, the narcissistic injury caused by society's rejection of those male transsexuals' picture of themselves motivated them to develop treatments that attempted to trap prepubescent children in a prepubescent state and allow them to be more successful in passing in their adult lives. Now, the psychodynamics of this are complex, but essentially these adult transsexuals wanted to create transsexual minors who could successfully pass in a way that they themselves had been unable to do. Psychologically, that would allow the adult transsexuals to vicariously experience... So psychologically, that would allow the adult transsexuals to vicariously enjoy the creation of physical proof that it is possible for human beings to change sex. Now, I want to be clear, I'm not saying that it is possible to do that, but psychologically, this would be evidence for those men that they could change sex, that it was possible for this to happen. And this would then reinforce their sense that their own failure to pass was caused by a hostile society rather than by the restrictions of human nature, which is the actual problem. So this leads to the question of how the narcissistic injuries experienced by adult transsexuals in the 20th century was transformed into a 21st century protocol for transitioning minors. Again, I'll be glossing over the details. Of course, Diana has gone into a lot more granular detail, but essentially a group of clinicians with personal and professional interest in the creation of this future generation of transsexuals able to pass developed an early version of the gender-affirming protocol in Holland that was published and became widespread, more widespread, that is, in the 2000s. And a key factor was the substitution of the clinically undefined word gender for the clinically determined word sex. Again, Diana has beaten me to this punch. Now, I'm not going to really discuss this except to say that the only clinical function of the word gender in paediatric gender medicine is to disguise the self-evident truth that it is impossible for human beings to change sex. This is literally a word created to obscure that fact that is self-evident to everybody. Now, the protocol was largely developed by activist clinicians in Holland, and it included all of the same treatments that we use today: puberty blockers, hormones, and sex reassignment surgery. But it targeted a very specific population of male patients who had shown stable and sustained evidence of transsexual identity in early childhood. So on the basis of this single exploratory clinical trial with a very specific group of patients that had fairly strict inclusion criteria, and even then had fairly unreliable methodology that generated very contentious results, on the basis of this single exploratory study, the Dutch protocol has now been used to justify the gender-affirming care paradigm that's used on Australian kids in paediatric gender clinics today. And rather than this small group of male children with early stable transsexualism, current paediatric gender clinics are treating thousands of gender-confused children with no well-defined clinical characteristics and high rates of psychiatric illness and self-harm. So, in addition to recklessly expanding the number and types of patients, gender-affirming care in Australia doesn't actually require the diagnosis of an illness to start vulnerable kids on a treatment pathway of social transition, puberty blockers, hormones, and eventually the amputation of sexual organs. Instead, it really only requires two things. First, for a child to say or do anything that a clinician can interpret to mean that their gender identity, which has no fixed clinical definition, does not match their biological sex. And second, for the child to request gender-affirming treatment, whether social transition, puberty blockers, sex hormones, or surgical transition in the later stages. So, this protocol lacks all of the traditional features of medical treatment designed to protect patient safety and improve patient health. That is, it doesn't require the diagnosis of a disease. Gender-affirming care is designed to affirm an identity, not to treat an illness. Not unrelated, it has never been reliably demonstrated to improve patient health or mental health. And in fact, its advocates are now starting to say openly that the goal of gender-affirming care should be respecting patient autonomy, not improving patient health. They are moving the goalposts. And finally, it lacks the most basic follow-up of patient outcomes. So, for example, patients who detransition are effectively dropped from care, leaving them without health support, and they're usually then exiled from what had been their main sources of social contact, which were other transgender people and the gender-affirming infrastructure. So if gender-affirming care is not medicine, then what is it? Well, fortunately, the definitive character of gender-affirming care is revealed by the process that it uses to decide who receives treatment and what the treatment will be. So in traditional medical care, the doctor identifies illnesses based on symptoms and investigations and offers treatment only to patients that the doctor believes will benefit from treatment based on scientific evidence. In gender-affirming care, the doctor abandons all their traditional clinical responsibilities. The patient self-diagnoses based on subjective self-report. They have the right to demand any affirming treatment, whether or not the doctor can point to evidence that it will benefit their health or mental health. And as there is no definition of treatment success, there is also no definition of treatment failure. And this is proved by the fact that detransition itself is not considered to be a failure of gender-affirming care, but simply another phase of treatment. So this is described as your pathway through life. You used to want to be a boy, now you want to return to being a girl, and tomorrow you could be genderqueer, which I'm not sure anybody really understands. So, again, the question, given that gender-affirming care is not medical treatment of an illness, what in fact is it? Well, advocates have explicitly described access to gender-affirming care as a human right and consider the refusal to provide it based on usual medical safeguards as the denial of that human right. Now, demanding the provision of a human right is a political act, while refusing treatment because it will harm a patient is a medical act. And I think that this proves that paediatric gender medicine clinics have been set up across Australia in response to political demands, not in response to requests for medical treatment. Now, it's no coincidence that the gender-affirming care for kids started to explode in the mid-2010s. The political pressure for this type of care started to ramp up as the campaign for same-sex marriage reached a successful conclusion with the plebiscite of 2017. So all the infrastructure that had been designed to pursue gay rights had relied on same-sex marriage as their defining symbol, and it was clear that the movement needed a new symbol to justify ongoing funding. Now, there are many activist organisations focused on gay rights funded by government and by private donors, but I'm just going to discuss one example. So ACON is the modern name of the AIDS Council of New South Wales, which was set up in the 80s to combat AIDS at a time when AIDS was an untreatable and fatal illness. Now, 40 years later, ACON has evolved through several iterations into an umbrella gay rights organisation which attracts millions of dollars of government funding. And it also benefits as a credentialing body that certifies public and private organisations are sufficiently compliant with ACON's vision of workplace equity. And these organisations pay ACON thousands of dollars for certificates and often much more for corporate training of their employees. Thus, ACON makes millions of dollars every year by forcing public and private organisations to adopt and in turn force on their employees a political agenda. So while ACON was set up to support AIDS patients, effective treatments became available in the late 90s, so the focus and the funding switched to expanding more general gay rights, and same-sex marriage became the central symbol as the push continued into the 2010s. But when same-sex marriage was achieved, ACON adopted trans rights as their next big fight, and they continued to receive millions of dollars to act as cultural enforcers for progressive ideologies, including gender-affirming care, on demand for Australia's gender-confused children. So ACON is an example of a highly organised activist group which is well practised at applying political and commercial pressure, but of course they started out pushing for the creation of AIDS clinics. So they have specific expertise in leveraging the political will to establish, fund and expand paediatric gender clinics. They have been very successful at pushing their agenda, but their methods are similar to those of other less visible and less formal groups. And at least to my mind, an important example emerged in the last couple of weeks when it was revealed that the BBC, the UK TV station, effectively has an internal LGBTQ plus lobby group that vets all coverage of LGBT issues by what is the UK's largest cultural institution. Now, the BBC has effectively acknowledged that this group does exist and that it prevents coverage of any story that might harm the gay rights agenda by forcing the resignations of Director General Tim Davey and Head of News Deborah Turnus. This wasn't the only problem, of course, but this was one of the features that led to those fairly senior executives being let go, and I think it has been acknowledged that this was a significant reason for them being let go. Now, in particular, this informal veto group within the BBC has prevented the UK public from understanding the harms of gender-affirming care. Now, psychologist Claire Rowe has written in the Financial Review about the similarities between the BBC's LGBT lobby and the infiltration and influence on the ABC in Australia by groups like ACON. And I think, in fact, Women Speak Tasmania have reproduced this article on their website. So if you go to the Women Speak Tasmania news site, you'll be able to read Claire's article. And I don't think there's really any doubt that the ABC's almost blanket refusal to platform gender-critical reviews is one result of this type of influence. Now, it might be a one-hit wonder, but the fact that ABC's Media Watch critically analysed the ABC's failure to fairly cover both sides of the trans debate, at least to me, suggests that some people in the ABC are at least reconsidering their approach to this issue. Another indicator that expanded access to gender-affirming care for gender-confused kids has more to do with politics than with medicine is that it has relied upon a series of legal cases with the Australian Family Court steadily reducing legal oversight of what is still an experimental treatment. But it's also becoming clear that the court has been relying on bad faith testimony by gender-affirming doctors when it made those decisions. So earlier this year, Judge Andrew Strum wrote the decision on a case called Reed Devon, which examined which of two parents should have responsibility for their 12-year-old son's health decisions. And Judge Strum overturned the court's previous tendency to uncritically accept the testimony of gender-affirming doctors when considering the well-being of gender-confused minors. And Judge Strum emphasised that Dr Michelle Telfer, the main architect of gender-affirming care for Australian minors, had failed in her duty to provide unbiased testimony to the court. He noted that Dr Telfer referred to herself as an advocate rather than as a medical professional, and that her priority was expanding access to gender-affirming care rather than improving the health of her patients. A fairly serious violation of medical ethics. Now, perhaps even more significant, Judge Diana Bryant, who led the court that made it easier to prescribe puberty blockers to Australian kids in 2013, has recently admitted that she would likely come to a different decision if she knew then what she knows now about the risks of gender-affirming care. And of course, she was relying similarly upon bad faith testimony from medical experts. Now again, I think this highlights the political nature of gender-affirming care. Judge Bryant really has recommended that legislatures should step in and regulate paediatric gender medicine because judges have been unable to arbitrate effectively in this area of practice because they can't rely on the testimony of those experts. And in my opinion, the only reason that those medical experts, like Dr. Telfer, with an open bias towards the rapid expansion of gender-affirming care, the only reason they were able to mislead the Australian courts for so long is because the rest of the medical profession stood back and let them do it. I'm just going to jump over a couple of slides in the interest of time. Okay, so trans ideology has been adopted across the medical, legal and educational systems. So full reversal will require changes in all of these areas. We will probably have to take it one step at a time, of course. But luckily, the most important factor in reversing the harms of paediatric gender medicine is to make as many people as possible aware of its ridiculous assumptions and harmful methods. When an international consulting firm did a strategic review for trans rights organisations in Europe, they concluded that the more people know about trans claims, the less popular they are. They recommended that trans activists avoid all publicity, focus all of their efforts on changing the minds of decision makers, and attach their claims to more popular movements like same-sex marriage, and this would allow them to avoid the public dislike of what they were trying to do, get things enshrined in legislation and dealt with in the courts, and by the time anybody noticed, it would be too late because these things would have been firmly enshrined in practice. Now, in my opinion, the most important change required in any of these different systems is to reverse the disastrous removal of the definition of sex from Australia's Sex Discrimination Act. And of course, we saw Anna Cody claiming not to know what a biological male is. There's no one in this room that believes she does not know what biological male is. She is taking a political position that is directly in conflict with reality because she was in the Senate Estimates Committee, I think, and so she realised that if she took a particular position, she would not be promoting this particular agenda, even though what she was saying was patently absurd. So look, I think Australia's legislatures need to follow the UK courts and reassert the biological basis of the categories of male and female. And in addition, as recognised by Judge Bryant, laws need to be changed to recognise the experimental nature of gender-affirming care and prevent the harms being done to children. Finally, something that Diana has spoken about before, the conversion therapy laws which have made it dangerous to treat gender-confused kids with psychotherapy must be reversed. Now, to my mind, the best overall analysis of paediatric gender-affirming care is in a report by the US Hospital and Health Service, which was released earlier this year, and their basic conclusion was that it's completely unethical for any doctor or health system to offer a treatment to children where the harms are serious and certain and the benefits have never been reliably demonstrated. The medical profession in Australia, and particularly the medical colleges representing specialties like psychiatry, physicians, GPs, must reject the political influence of pressure groups like ACON and insist that gender-affirming care be banned until there is acceptable evidence that it improves patient health and doesn't harm. And I'll skip over the educational. Now, in conclusion, I believe that the rollout of paediatric gender-affirming care essentially has been the culmination of organised pressure across the political, legal, medical and educational systems. As a result, its reversal will require changes across all of those systems. The most important change is that reassertion of sex over gender in Australian law. And then following that, we need to follow the US, UK and other Europeans in banning these harmful practices. And finally, we must develop more effective methods for treating the psychological causes of trans identity and allow gender-confused kids to reintegrate the dissociated male and female aspects of their personality so that they can live as non-confused adults. Something that Diana has been doing a lot of work on. Thank you.